ALL, most of the studies have shown that if we use a pediatric-based regimen that say have PEG asparaginase, we have a better outcome. There's no head-to-head without regimen without PEG asparaginase, but we know they are better outcome from the control data that we have historical data to compare to. So if someone comes in and say they are Philadelphia negative, and they are say under the age of, I don't like cutoff, but under the age of 50, I would like to use a pediatric-based regimen that have PEG asparaginase in it, like LGB 100 or 4 or 3. And then if they are actually in low risk and they are MRD negative, that's it. We just continue on the maintenance, consolidation and maintenance, which goes up to 2.5 years. Now, if patient doesn't respond and still have MRD positivity, we should offer for them blinatumomab followed by transplant. Now, if they unfortunately don't respond to the initial treatment, or they have refractory relapse disease, they relapse after the initial treatment, then the options become either CAR T-cell, or become blinatumomab, or become the inotuzumab, which is a monoclonal antibody for CD22. Now, I always prefer that patient goes into blinatumomab initially, and the reason is that inotuzumab, which is a very effective medication, unfortunately have a risk of VOD up to 10%. VOD is a veno-occlusive disease that happens after transplant, and it could be deadly. So if I can get them into remission by blinatumomab, I do not want to try inotuzumab. However, if they are not transplant eligible, they are elderly or they have a lot of comorbidities, then inotuzumab plays a factor. So if they're transplant eligible after initial therapy not working or relapse, they go into blinatumomab and then go into transplant. If they're not transplant eligible, or if they fail blinatumomab, then they get inotuzumab, and then transplant is on the table even though there's a VOD risk, just that the patient need to be aware of the VOD risk.